Have you ever wondered why weight loss feels so different for different people? Why some people can make a few small changes and see huge results, while others feel like they're doing everything in their power and their body does not want to change? I'm naturopathic Dr. Hussain, and this is Phase to Phase, the Hormone Health Show. Today we have our first guest, and we're talking about weight loss, which is a complicated topic, a topic that can bring up a lot of assumptions, emotions, unsolicited commentary, and a lot of bias. And I'm pretty sure we've all heard that vague advice, sometimes even given in medical offices, to just go eat less and move more. And yes, caloric intake really matters, but it isn't just about willpower, like some people make it seem out in the world and on the wild webs of the internet. It's about biology, your genetics, your environment, your upbringing, trauma, stigma, access to nutritious food, safe spaces, housing, healthcare. And honestly, it's even just about luck, the luck of the draw with your family and geography. And weight is one of the most stigmatized aspects of healthcare, and health professionals are only human. They're also privy to the same biases and the same diet culture and reductionistic messaging that everyone else gets. Yes, excessive weight gain or excessive abdominal fat or visceral fat can have significant implications for your health and your long-term heart disease risk, but you can improve these risk factors even with a modest reduction in something like waist circumference or your overall body weight. But a cookie-cutter approach is not the way. You need a strategy that accounts for who you are, your biology, and your individual health goals. And today we're cutting through the noise and talking about weight and weight loss in a way that acknowledges all of that. There's a complexity in this issue, and there are real health benefits that can come with safe, sustainable change. We can hold all of these realities together without reducing someone to their gravitational pull to the earth. And I have a guest who I'm so excited about, and there's no other better person to help us do this and tease everything out than Dr. Ashley White, who is a medical doctor and diplomate of the American Board of Obesity Medicine. She's developed the SHIFT program, a signature transformational system using her cutting-edge evidence-based approach to weight loss the right way. She uses common clinical pillars of weight loss, such as behavior change, meds, surgery, nutrition, and coaches patients to see their own capacity for change in the direction of their values. She's coined several key concepts that we're going to get into today. I have had the pleasure of working with her and connecting with her in a clinician group, and I really appreciate her well-rounded approach to obesity medicine that really acknowledges the person sitting in front of her and the person sitting in this world we live in. Welcome, Ashley. Thanks so much for being here.
Thank you for having me. This is really exciting. I can't believe that I'm the first.
I think you're going to bring some nuance to this conversation that is much needed in today's world, especially on social media when we have these short-form captions and this short-form content that doesn't really focus on all of that, right? And I do want to start right at the beginning because I think many people who are listening or watching will have heard the advice to just eat less and move more, or you need to be in a caloric deficit. Can you explain to us what that means in the context of weight loss and also shed some light on why that advice falls short very often?
I have started thinking about this and talking about this in a way that captures this truth that your energy intake has to be lower than your energy burn in order for your overall mass to go down. That's the law of thermodynamics. We can't say that is not valid. However, over the years, in particular the last 3 years, by listening to women, I have developed this knowing by trying to resolve the tension that happens when a patient says, I am not eating very much and I am not losing weight. Historically, the classic training is to assume that the patient is underestimating their intake. And, there are some studies that show that people underestimate their oral intake by about 800 calories a day on these food diaries. And I do think that does happen, particularly phase to phase, to borrow an expression, because people do have really, really altered appetites at different phases of their menstrual cycle. However, I started believing my patients about 3 years ago that, oh, there are quite a few people who eat very little and cannot lose weight. So they are already following the advice that they have been given, and they are exercising, sometimes quite a bit, in an underfueled state. And they are holding on to tissue, particularly concerning tissue that is inflammatory fat around their organs. And it is destroying their mental health because they feel like they're being gaslit by their own bodies, basically. And they are. So the way that I like to think of it, instead of calories in and calories out, I really like to think about the in component being the appetite, the what goes in, what is the fuel complement, and the out component as the metabolism. So the change, so how your body takes fuel, breaks it down, takes food, breaks it down into fuel, how your body partitions that energy into muscle, fat, bone, fuel to be used immediately, fuel to be used in a few hours. And so if we take those broader concepts of appetite needs to equal metabolism if you're trying to remain weight neutral, or appetite is a little bit lower than metabolism if you're trying to lose weight, and you understand that the body is a dynamic system. And if you try to hack it with a large caloric deficit, if you try to speed things up by eating 1,200 calories a day, unless you are a very, very small person, this will backfire. And it will probably backfire right before your period. So you have to give yourself the grace of understanding that you are a system of systems. And the work is about figuring out what is the appetite, the one that I'm aware of and the one that I'm not aware of, that I can't have any conscious awareness of. What is my metabolism actually? What do the calculators say? What do body composition analyses say? What signs do I have in my blood work and my diagnostics? And then underneath all of that, actually one of the most important pieces of all of that is the perspective. So I call it the MAP, the map, because it's a simple way of thinking about it. But the perspective is, what is the story that you're telling yourself about all of this? Because you have to work on all three. Because even if you are operating at a caloric deficit, you figured out how to influence the levers of your metabolism and your appetite, but you are still treating yourself with hatred or with, weaponizing the bias that you hold against people who are large, against yourself, it won't move the needle. And that's the nuance. And that's where it takes a lot of skill, not only clinical skill in terms of like applying the knowledge, but also bringing the patient to that awareness takes time. And our system is lacking in time.
Yeah, it's short appointments are not really conducive to even going over some of the factors, albeit like all the factors when it comes to weight and body image distress and disordered eating patterns that oftentimes coexist in patients who have struggled with their weight or attempted to lose weight or attempted to control their intake. And I know you have a personal connection to this topic. Can you actually, let's take a little trip down memory lane, maybe? Can you share how you came to thinking about obesity medicine and weight in this way and what your personal connection is?
Yeah, I have my own personal experience of obesity, my own personal experience of being quite underweight as well. I have been about 100 pounds in either direction during my adult life, and have been able to give voice to the experience of a lot of my patients because it's also my voice. And that has catalyzed for me insight after insight after insight from these clinical experiences, because they mirror my own, and they've allowed me to really release like so much bias against myself, but then also just like the stuff that I was taught as a medical student, as an early doctor. I grew up in a family that was diet obsessed, that was weight obsessed, where speaking about people's bodies was normal, and where the religion of willpower was the place we worshipped on Sunday. The pull up your bootstraps, I just have to try harder. This is my own problem. But then if you examine the genetics of my family, if you really take a step back and you see what I now see, you can see that there is a largely inherited appetite genetic deficiency in our family. Lots of my members of my family have had bariatric surgery. Lots of members of my family have had experiences of obesity that have made it so that they are excluded from participating in society in a way that we know it. And by doing the work that I'm doing through my own patient experience, through my own treatment experience, I was able to both be horrified by how poorly we do this work compared to how well we could do it. And then also that I'm sure I have treated people the way that I treated myself. And that's not fair to anyone because I didn't know. And one of the risks of being both a patient and a doctor is that you can become an evangelist for a certain way of thinking or a way of being treated. And I don't think I've done that. And the reason that I don't think I have is that very early, there was a group of women. This was the first group of women that started telling me this. Is they would say, hey, this thing that is this medication, in this case it was a medication, this medication that appears to be working for everyone because it's all over the news, it doesn't work for me. Like it just doesn't, like I'm doing all the things and it's not working. And that's where I really had to be aware of my own patient bias of the disease of obesity and make sure that my own experience, my own pain, my own, positive experience through treatment was not clouding my clinical judgment. And that's where the development of frameworks and language and systems came about so that I could share it and teach it, and we could develop an entirely new vocabulary for how to talk about weight in clinical practice and amongst each other. My commitment to this work is very much about making it so that my daughter, who is also going to be a real big girl, just doesn't have to lend any real estate in her brain to this stuff. She's going to be big. She's a hungry person. She's a big eater. So is my son. They're going to be big people. And it is very, very important to me that they can hold that as true, but not hold it as something to be contained. And that's the mission here. And we spend a lot of time working on bias. I think of it as core to the pathology. It is a driver of the pathology, which is why perspective is that final part of your metabolic picture. And I have so many patients that once they get to that bias release part and they are invited to see themselves differently, that's when their health transforms. It's a mystery I don't really understand, but it happens. So it's cool.
It is cool. Thanks for sharing all of that. As you know, I work with a lot of patients with PCOS, and I have PCOS, and it's so interesting. And I think we're both overthinkers as well. So it's very interesting to think about our own journeys, holding that at like an arm's length almost, but also keeping that in mind as we approach patient care. And I love something that you said because I resonate with this a lot. Working with patients so closely, has normalized so many things for me as a human. And I always hold that with such a privilege. Like, I really think that it's a privilege to be exposed to all of that over time, because like even like looking at bodies up close and looking at people's brains and their fears, and I'm like, okay, well, I'm not alone in this. But not everyone gets to share that, especially in this space we're in, where yeah, people share some realness and rawness online, but we also see stuff through significant filters, right? Like especially by the perpetuators of like diet culture and beauty ideals, if we look at the celebrity culture and media, right? So it's such an interesting juxtaposition of all of that, and it's kind of fun to hold all of that, but also it comes like with a weight for sure, and I think it's always evolving. Um, Now, going back to this topic, there's obviously, as you already mentioned, there's a lot of different things driving appetite control and how that metabolism is working and how much we're putting into our bodies. What are some of those factors, whether those are biological but also environmental, right? Because I think we can't separate the infrastructure that is around us, that and when you have like an intersecting identity of some kind, like those populations really slip through the cracks. And I know you also come from a background of working with rural populations, so can you shed some light on some of those factors?
Yeah, all health is political. It just is. We are we are systems of systems, but we are systems inside systems. And there is overwhelming evidence that our environment influences our metabolism and our appetite. And it does so through several means. There's things like endocrine disruptors, essentially, which are micro, let's, for the sake of not feeding the misinformation sphere, they are chemicals that exist in our environment, and they may have a role in interrupting our endocrine signaling, specifically as it relates to the way our fat cells communicate with the rest of our body. And it may be more important for women because of the way that they distribute fat. They have a higher body fat percentage in total, and their hormone signaling is different. That has a clear impact on body size. Also, from an epidemiological perspective, the obesity epidemic really began in earnest in the Western world in the early 80s. And we didn't all of a sudden lose all of our willpower in the 1980s. Something has happened, and it is tied, obviously, in a way that none of us can say that this is causal, but that shouldn't stop us from at least considering and taking action against an environment that is harming us. So that is the most sort of physical and tangible way in which our environment influences our actual fat signaling. But then there's also all of the other things. There are, how movable is the place that you live? How car dependent is the place that you live? The rise of, the data on whether physical activity has actually resulted in altered metabolic burn is a little mixed. So there was a great article that came out on my birthday, actually, this year. It's very exciting. It's called the CNS control of homeostasis, or of energy homeostasis. It may be brain control of homeostasis in cell metabolism. But they discussed this idea that a lot of the prevailing theories around, the way that our orientation to work, for example, has changed our metabolism. They don't actually carry a ton of evidence. So we have not become vastly different creatures since the 80s. And that really points to the environment as it interacts with our genome, a phenomenon that we call epigenetics, where there is something about the way in which our DNA butts up against a rapidly evolving, rapidly industrializing environment that has turned on obesity as a disease for lots of people, but not everyone. The people who are disproportionately affected by this are people who were, so people who have come from particularly South Asia and East Asia to Western environments where they have had a dramatic shift in the environment, and a small amount of weight gain in a South Asian or East Asian person can result in quite a bit of disease in a way that is not happening necessarily in people who are white or Black. And that speaks to the ways in which different bodies are genetically primed to hold on to tissue and to fail to remain well, or hold on to basically your resilience against developing diabetes, for example, is influenced by your genetics. But a rapid shift in your environment, generation to generation, can make it so that diseases that your family never had to deal with are now killing people. This is really complex stuff. And I think my role as a clinician is not always to rally against that. I have to point it out to people as part of the way that we can help release some of that pain and that bias, basically. But I have about 18 diagnostic filters that I work through with patients in practice. And the reason this is hard is because this is a transdiagnostic model of assessing for obesity. So when someone's come to me and they say, I am gaining weight, or I have gained weight, or I have been in a large body my entire life, or I've been in a large body my whole life, I've already been to all of the treatment programs, I've already had the surgery, I've already had a revision to the surgery, all of the things, and now I don't know what to do. I even took the Ozempic and it didn't work, right? Like, there's even those stories. And inevitably, at some point in one of those diagnostic filters, the reason becomes clear. And it doesn't mean that I necessarily deploy magically different tools. I don't have a magic potion, right? But in applying those filters, the patient is expressing, if you listen, they will tell you where the problem is. And sometimes those problems are really a lot about like how they have to spend their days. And I think a lot about women in midlife and the impossible ask of women in midlife right now. And that's the feminism of it all, that a lot of people are working through. But also a patient, if you allow them to give voice to the things they've been thinking, but they haven't really been able to say out loud because they haven't had time. No one's asked. They haven't had time, and they haven't put those dots together. And now in my assessments, the wheels are like cracking along in my head. ADHD, PTSD, complex PTSD, stress, menopause, PCOS, atypical PCOS, atypical anorexia, atypical bulimia nervosa, chronic underfueling, PMDD, and on rare monogenic obesity syndromes, polygenic obesity syndromes. Is this a rare tumor, like an insulin or glucocorticoid producing tumor? What is this, a pituitary mass? All of that has been found by listening. And I believe that we are capable of deploying a really strong model of transdiagnostic care, but we can't use our current primary care setup, which is why I've had to edge out into new territory. And I think that the audience is willing, both the clinical, the clinicians, but the patients they're so ready. They're so ready.
Can you, for anyone who doesn't know what transdiagnostic mean, can you just tease that out a little?
Yeah, so it's the opposite of what we have now, which is where we privilege and hold on a pedestal hyper specialization. So this all started because our human resource and clinician labor complement does not match the needs of the population, nor does it match our actual fiscal needs of our health system, which are to prevent chronic disease. If we could prevent chronic disease, everyone would be better off. But instead, we privilege the surgeon who has done 3 fellowships in minimally invasive 1, 2, 3, 4, 5. We privilege the reproductive gyne endo robot AI and like we privilege people who have been to school for like 20 years. Those are very, very incredible people, and they should be supported, and their wisdom should be spread throughout the system. Absolutely. They should not be relied on to make every diagnosis of PTSD or of PCOS or of genetic obesity syndromes or of menopause. Like, there's no way that we can do care that integrates input from multiple specialties in a way that reaches everyone if we don't have the courage to apply a diagnostic framework to someone, even if we might be wrong. In primary care, we have a problem. And I was trained as a rural family doctor. I didn't have any specialist supports for the first 5 years of my career. So I just went for it. I just learned to be like, why would I call endocrinology to manage this like relatively obvious case of type 2 diabetes? I don't have an endocrinologist. And so therefore I will just figure out how to do this before, these tools were commonly available. And so then I did. And my urban colleagues were scared out of doing that by the system. That's not their fault. We have decided that GPs are about quarterbacking the system, and there is a reluctance to say, I believe that this is what's going on with you. How about we try this? And even if I'm wrong, here are the harms of me being wrong. Here are the pros of me being right, and vice versa. Would you like to go on this journey with me? I'm not sure how it's going to go, but what if that was helpful for you? And then patients are like, hell yeah, let's do it. Like that's how I learned. I taught myself this work by entering into and by trying to adopt what I could from all of these different specialties, knowing that once I got to this weird and wonderful case, I phone a friend. That's what I do, right? But I'm sending people at the right time to the right place. Their home base should be in one person who could help them navigate a lot of different systems and spheres. And the idea that we are a bunch of compartments stitched together with skin and blood is absurd. We are not.
And, I really resonate with what you said about let's try this, because I feel like oftentimes as a naturopathic doctor, that's the position we're in, right? Like oftentimes people don't have family doctors, and I really want my patients to have family doctors, right? Like, don't get me wrong. Like, I would love all my patients to have family doctors. And I want them to have family doctors who listen to them and have a little bit of time, even if, it's not like 10 minutes, right? Like maybe it is like the full 7 minutes, right? To just like go through their hot flashes and their vaginal dryness and their anxiety all in one appointment, because they're likely coming from the same hormonal place, and the sandwiching that they're doing in their life of all the things and all carrying all the responsibility, right? And I think that's the beauty. And I always say this, like, I have the privilege of time with my patients, which means that they can tell me what's going on, and I can piece together a few other pieces. And I think that's also what drew you to work in a clinic with naturopathic doctors, right? Like, because you have great insight and strategy, but also you're limited by your time. And you can build this collaborative model, which really does serve chronic illness like acute medicine cannot, right? Because acute medicine is inherently different. It's in the name, it's in how we treat. And unfortunately, the conventional system is really built upon that, right? Like, oh, you have a bacterial infection, here's an antibiotic, right? And that is so hard when you have a chronic illness that will also change over time, because it's inevitable that it will change over time, because bodies change over time. And I think that's also part of the reason why women in midlife especially, or women with PCOS, I'm going to draw on those primary populations because I know you work with those populations a lot. I work with those populations a lot. There's so many things going on that sometimes it's very easy for them to lose hope. It's very easy for them to fall through the cracks, or aspects of or facets of their conditions or health to slip through the cracks. And I think where we really have done a disservice in the weight loss medical field or from the medical system is that we haven't talked about the relative reduction in weight and the benefits that it can have. Right?
Yeah,
Like we think that a person has to be like normal in a normal BMI category, or a person has to have X amount of waist circumference, right? But the benefits really lie in a reduction or preventing excessive weight gain over the future. And I think that's super. We have such beautiful data on PCOS with this. If we have like a 5 to 15% reduction, we can improve ovulation rates, we can improve fertility rates, pregnancy outcomes, decrease the risk of heart attacks. I think that data is like not fully there, but it's coming, right?
totally.
So
Absolutely.
I think those are the conversations that require time, but we can't have in primary care oftentimes. So can you actually go through some of the numbers or like that relative improvement and how
Hmm.
we can contextualize that for anyone listening or watching?
Yeah, I think people, one of the major areas of work that patients really need to do when they're coming into care is have their expectations uh, be clear. I guess if I back up, when I started doing this work, um, a lot of family doctors and a lot of doctors generally are aligned with the idea that you really shouldn't try to make every problem about someone's weight, right? Like it's actually a very, very stigmatizing experience to walk into a doctor's office and then have them and you be like, oh, like I have this mole on my arm. And they'll be like, well, if only you lost weight. Like, okay, whoa, right? At the same time, inviting someone into a curious and kind conversation about what would it look like for you to lose 5% of your body weight. What do you think would be easier? What would be harder? What would be different? How does that serve you? Those are really tangible things for people. It's usually an amount of weight that they have lost before because of the nature of diet cycling. It's an amount of weight that doesn't trigger instant like hopelessness and rejection. And it seems very manageable. And so if you talk about that 5% kind of thing, then you can just sort of keep the expectations in a really healthy sphere, and you can really take appearance off the table as what you're actually talking about. Because patients instantly think that you as the doctor mean like become thin. And that's actually not what is appropriate for a lot of people. In addition, if this is the first time you're seeing a doctor and you've already lost 20% of your weight and you've done the heavy lifting, right? Like your numbers have improved, your blood pressure is great, you're feeling awesome in terms of like running around with your kids or grandkids, you're sleeping better, your sleep apnea is like gone, you don't really like your sleep apnea machine is maybe collecting dust. Like there's all these things. You are still in a large body. You are still experiencing weight stigma. You are still being judged. However, you know that you've underwent the most difficult transformation, which is that first 10, 20%. We know that osteoarthritis of the knees starts really improving in terms of both quality of life outcomes as well as post-surgical outcomes at around 10% body weight loss. We know that hypertension, it's all on a gradient, right? But between 5 and 15%. We know that bariatric surgery, but also weight loss on its own, regardless of how it's achieved, will reverse type 2 diabetes in many cases, assuming that that beta cell function or pancreatic function has been preserved and is not gone. There are all sorts of ways in which, like sleep apnea, fatty liver, not going for a liver transplant is one of the things that losing 10 or 20% of your weight can offer you. There are so many tangible and real improvements to your well-being that come between 5 and 20% weight loss, regardless of the weight that you're starting at. That should be where we start with people. I knew that this was going to be a problem when I saw that our poorly equipped primary care systems were going to be given a very effective tool in the form of obesity pharmacotherapy, like drugs like semaglutide, tirzepatide, bupropion, naltrexone. These medications are widely available in primary care, but they are entering into a system that has no idea what they're doing when it comes to weight. And so what I saw happen was people would be put on Ozempic. They would lose, either they would lose like a lot of weight, right? Such that they were so underfueled that they were anemic, they were amenorrheic, they'd stopped their having periods, they were lightheaded, they were depressed because they had no appetite. And having no appetite is not a way to live your life. But every time they went to their doctors, the doctor would be like, look how much weight you lost. You look amazing. Oh my God, great. Let's just ramp up that dose. How about that? And you're like, okay, I don't feel very good. Oh, but like everything is great. And that is the way that weight bias affects people in smaller bodies. The assumption that because you are thin, therefore you are healthy. It also goes the other way. It's dangerous. And so this doctor doesn't have time to do a comprehensive fatigue workup in a person and isn't even really thinking about like day-to-day fueling as a problem. And it takes a lot to unpack what could be going on with someone who is overtreated. Also, all of the clinical trials on these drugs don't advocate for real-world dosing. They advocate for max monograph dosing. And our studies are based on the idea that everyone will be on the same dose. And that is not okay. The other side of it is that some people get on these medications that are ostensibly supposed to transform their lives like tomorrow, and nothing happens. And then the family doctor's like, I don't know, let's send you to endocrinology. Maybe you should have bariatric surgery. And that's also not enough. So I had to write an online program for people who are trying to lose weight so that they could be the most informed person in the room. I said, okay, so I have hours and hours and hours of conversations with my intensive patients over months. What if I could somehow get them to have those conversations with themselves, learn everything they need to learn, so prepare them literally with scripts and trackers to take into their family doctor's office so that they would be able to advocate for themselves, so that they would be able to understand things like metabolic adaptation. They would be able to understand like things like appetite literacy. They would be able to appropriately track their macronutrients and their fuel, make sure that they're not operating at an excessive caloric deficit. They would be the most informed person about where they're at, so that they would be able to compensate for our primary care system failures. And that's been really helpful, right? But it's really hard to teach all that stuff to people and to have it like, it's just so countercultural to what we've normalized. What I think is that what you asked? Yeah.
Yeah. And I actually, because you brought up appetite literacy, can you touch on that concept and what that means?
The weirdest thing about going on treatment was realizing that my appetite was it was like an operating system. It was like, oh, I was a Mac and now I'm a PC. And I didn't know that I was either. I didn't know that I had one. And then for it to just have been converted like that. And then I was like, oh, it seems as though I have never once learned in 20 something years of learning, like high level learning, what an appetite is. That is not a thing that has ever been contemplated by any clinician that I have ever been trained by. And what is it? and I was like, well, that seems like a real basic hole in the whole thing. And, you know, there are concepts of hunger and wanting were present in the psychotherapeutic literature. The concept of restraint is something that is sort of the root of CBT. That sort of hedonic, dopamine-related circuitry is well understood. There had been models of how the hypothalamus is a nutrient sensing, or parts of the hypothalamus are nutrient sensing and are very, very closely connected to the blood itself to be able to determine what are the body's minute to minute needs. But there had been no holistic orchestration of the appetite, right? And recently, like 2024 and 2025, there were tons of papers that are coming out about this, which is great. Interestingly, I developed my concept of appetite literacy based on like a bit of gut feel. And then all of these papers just seem to be endorsing what I lived through, which is a real nod towards lived experience, in my opinion. And I was like, oh, if patients are going to be able to advocate for themselves, they need to be able to communicate about what it is they feel with respect to eating. And what is interesting is that the new crop of medications, which is the first crop, there's going to be many, many future crops, they are appetite modifying medications. They do not modify metabolism. And so if you are a person whose appetite is already a little bit messed up because of years of dieting, because of high levels of insulin resistance, where you just have no drive to eat in the morning and all your drive to eat is at night. Let's say you're a person with ADHD, you have very unstructured meals, there's a lot of chaos in your eating, and then you are all of a sudden given a medication that eliminates your appetite or even just reduces it by X%. You then are going to feel a lot more comfortable day to day. And in the beginning, it's going to be easy to accidentally underfuel because you're not a person who has structured eating anyway. So you're underfueling like with a dramatic caloric deficit, right? And in your head, you're like, well, I'm losing weight. This is all very good. I'm becoming healthier. But in doing so, if it is not paired with, adequate fueling, enough protein, enough micronutrients, as well as activity, you are very likely going to both downregulate your appetite, but also downregulate your burn rate, your metabolism. And then you're going to get to a lower weight, but you're going to be, the gap between your burn and your consumption is not necessarily going to be a lot smaller. Now, once people lose 30% of their body weight, and sometimes over that, regardless of how fast they lose it, some of that burn reduction, that metabolic adaptation, it doesn't go back to normal once you go and build that muscle back or gain weight. It makes it really easy to gain weight, and that weight is just fat. So you can eat very little, gain, and only really gain fat, which is metabolically not that useful, right? It depends on what kind of fat, but most of that fat is not useful. And then you're back worse off than you were before because your metabolism is now lower, you are under-muscled, and you are not eating very much, and you don't feel well. So there is a risk that if patients don't know themselves and can't put some guardrails around that and don't understand the language of hunger and wanting and don't recognize that having your appetite be obliterated is actually not the objective here, then they are going to do more harm than good. And that is what I see a ton of, which is really sad.
Yeah, and I think you've hit on a few very important points, right? Like from both the practitioner's side and what is lacking there, and the patient's side and what their understanding is. And really, the communication piece is where we need to meet patients, but it can't exist if the practitioners aren't well versed in that in the first place, and we're holding the same biases and that stigma around weight, and we're trying to just shrink everything without the context of the person sitting in front of us and what is good not only for weight but also their longevity, for their functionality, for their day-to-day, right? And as someone who works with a lot of women, like my practice is primarily women, women are already prone to shrinking everything, right? Like shrinking themselves, shrinking their wants, their desires, their food intake, everything. And then there's a lot of shame that comes with not having discipline. And this leaves them nowhere better, right? Like it perpetuates this narrative that we already get exposed to over time.
The great part about appetite literacy is that around like 10 to 12 weeks of working with this concept and this language, my patients then start really thinking about food as fuel, not in a like hyper disciplined, like boring way, but like I got to make sure that I get time for a good meal in. And you're going to be so proud of me. I just really ate super well. And like they become like lifted. There is a fullness to their experience as humans because they are fueling. My patients take a bit of time to believe me when I say, I need you to eat more food so that you can lose weight. And they're like, come on, are you crazy? And I'm like, I am not. And the proof is in the pudding. So how about instead of going for a 1,000-calorie a day deficit, largest deficit you should be looking at day to day is 500 calories. We have been able to create a real global understanding of what is driving your weight up and down. You have a pretty clear understanding of what levers we need to pull, regardless of how we pull them. Your job is to eat. Your job is to feed. There's nothing wrong with it. That permission is everything. And once they decide to give themselves permission, I seem to have a lot of peri and postmenopausal women who are losing weight, building muscle, eating at a small caloric deficit, but nothing major, and feeling awesome. Awesome. That's the most like rewarding part of it for sure.
Yeah, and I think you brought such a good point up because I think women, especially because they tend to not front load their day, they start off at a deficit. And I explain this to patients all the time. I'm like, if you need to be at, let's say, if you want to be at, let's say, 80% even, and let's not even talk about 100%, let's talk about 80%, and you're waking up, hopefully you weren't eating in the middle of the night while you were sleeping. You're starting at the bottom. And if you're not eating, what's happening is that the deficit that you've created now in terms of what your body needs to feel well and where you actually are is huge. And it's really difficult, pretty much impossible to recover because by the time you make up for those calories, right, like the body will send you signals later in the evening, right? So like the benefit of even just front loading your day and eating a proper breakfast really, and I see this with patients all the time too. And I always preface it by saying, I'm like, this is going to sound really basic, but let's focus on breakfast. We're going to focus on getting more protein at breakfast, more carbs at breakfast, more fats at breakfast. We're just going to have a little bit more breakfast. Or even those people who work out in the morning because that's the only time that they can work out. I can't relate to that because I don't work out in the morning and I'm not a morning person. But you know, you do you. But same thing, right? Like if you're working out in the morning in a fasted state and then they're like, oh my gosh, then I feel really energized. But by the time I hit midday, I just can't get through. It's because we've created like this ginormous caloric deficit, this fuel deficit that is so hard to make up for. And not just that, when we add in just even a few bites, because like you don't want a lot of food sloshing around. I get it, especially if you're doing cardio first thing in the morning. But even a little bit actually makes your exercise more effective because guess what? Food is fuel. Who would thunk it?
Mm-hmm. And food is fuel for your mood.
Yeah.
Like people who have depression don't eat. And in order to heal from depression, it is better. You need to eat. There is a nutritional therapy component to healing from depression. There are some people who do excessively eat when they have depression. That is actually a small percentage of the population, and we probably think there's mechanistically something else going on with them. But for most people, what they call emotional eating is often just a reaction to a fuel deficit that declares itself late at night when they've taken care of everyone else but themselves.
Yeah. Now, I want to wrap up with a few sort of positive things and also like how people can advocate for themselves if they are either being told that they need to lose weight or if they will benefit from a little bit of weight loss, whether that is for, let's say, their cholesterol levels or for their blood sugar or cardiovascular disease risk or something else. Um, how can people have better conversations with their family doctors? Like, what are some tips and tools that you can offer to anyone listening to this episode?
I advocate for people to not be shy, to remember that their doctor is human and they're working with impossible constraints, and that the patient, you have to be the expert on yourself. And if you can enter into your 7-minute appointment with a clear agenda, an acknowledgement that probably everything on that agenda will not be touched, but having them prioritized, um, demonstrate that you have thought about where you're going with all of this, and demonstrate that you understand what it is you're trying to achieve here. If you are if if you are trying to achieve like a better marriage or a better job or a better, you know, garden or something with weight loss medication, which is the fiction that many people live in, then you get to back on up and then go in to your encounter with your doctor with a story that is actually like, I want to lose weight because, right? And I feel like this is the amount of weight where a lot of my health concerns might be manageable. I might have just a lot more confidence in my ability to like follow through with a plan. That feels really good. Also, don't wait for validation from your doctor. Like that's it's not it's not our job. It's not our job is not to give you health. Our job is to leverage whatever acute care tools we have, and then that's and I'm not saying that this is right, but that is what is happening right now. I would say that even if the doctor treats you poorly, which happens like all the time, it doesn't mean they're right. You are you have a you have a right to good treatment. However, family doctors are very scarce. Do not give one up. In my program, I have a conversation guide. I have a lab result tracker. I have a body composition tracker. I have an agenda setting script. A bunch of those things are actually free. Like you don't have to pay anything. Those are online. But then there's other tools that are inside the program. And I, I there's not like one trick, but there is an invitation to be the expert in your own story here. Even if your doc doesn't agree, doesn't matter because you're the expert.
Apart from family doctors, what other lifestyle modifications or tools or health professionals can people utilize on their journeys? Because I think with weight loss, especially if we look at the data, long-term success really does come with accountability built in, right? Like whether that's a dietitian, how do you encourage patients, or when you're building out with your patients, and obviously we'll take this with a grain of salt, what other medical levers are we utilizing in order to facilitate success over the long run, to especially from a health standpoint, right? Like I think we as medical professionals, healthcare providers, are looking at it mostly from a health perspective, which includes mental health for sure, right? But yeah, how do you help people curate a team for themselves that will facilitate their long-term goals?
Yeah, I think it really depends on the diagnostic complement. So lots of people really do need to work with a therapist or a coach or a social worker. Some people do need specialists. Surgery, psychiatry, gynecology is a big one. Pelvic floor physiotherapy is an unlock for a lot of people. Um, and medications. So I use a lot of on-label and off-label medications. I treat holistically. We make game plans that are chronological. Like these medications, because we need to stabilize the situation. These medications are probably going to be with us chronically. These, I am not the supplement expert. Our naturopathic colleagues are really going to help guide things like iron replacement, micronutrient replacement. So that's how I set it up. In the beginning, in our sort of big assessments, I connect each of these diagnostic elements to a team member. But I think when it comes to that long-term success, the stuff that really brings people back is community. Like, that's big. If people feel safe, and my current challenge is that there are not a lot of places to go for people where they are not going to be faced with a lot of diet culture. Instagram right now is a cesspool. There is almost like worse. It's like worse than the 90s and like the heroin chic era. It's back big time, and it's really destructive. And it's really destructive for young girls and young kids. I do believe in treatment as prevention. I do think that there are kids who would benefit from early obesity intervention. However, the risks of doing so are so high because the culture is so oppressive around women in particular right now, and what it means to be a feminine woman or a good woman, or, you know, one who deserves to be seen. So I'm really concerned about the kinds of communities that people have right now. Most of the time, these are big companies with big profit motives. So Weight Watchers is a really strong community element, like the original community element. But they're like, they want to tout X% weight loss in X weeks. That is like what their shareholders want. That's what the Noom shareholders want. That's all, like, that stuff is all there, you know, and Living Method is, you know, a multi-investor situation right now. And everyone is like trying to demonstrate benchmarks of success outwardly. And where is the psychological safety among peers about, like, hey, yeah, I'm not saying I don't want to lose weight. Like, losing weight to a point is actually valuable to me. I have that as part of my strategy, but it is not my it does not define my strategy. And so what I've done now is, for 2026, we're launching something called the Weekender, which is where 8 times a year you can come. We're going to do a 3-hour session on Saturday, a 3-hour session on Sunday. And you can actually, you're going to map out your entire wellness strategy with a community guided by me. And I sort of walk people through it, so that you then get to, like, kind of shut out all the noise and just, you've got your strategy, you've designed your plan because you know who you are, you know what you need. Boom. And then every 8 times a year, you get to come back, you get to do that. Because I'm like, people need a place to get out of the toxicity. It's just so bad right now. And there's so much bad information. My God.
Yeah. And a lot of, at the as I said at the top of the episode, like, unsolicited commentary on people's bodies, which is a topic for another day. Uh, um, Ashley, I want to thank you for this conversation, and B, I actually want to end each guest episode with something that you've changed your mind on, because here at Face to Face, we're really keen on being conscientious consumers, growth, learning, and unlearning. So I know I have changed my mind about a lot of things over my time. I would even say that sometimes I really cringe when I think about young Anne and some of the thoughts and beliefs that she had.
Same.
Even around weight loss, right? Like, I have come a long way, definitely held significant weight bias and weight stigma, and really had to work through that, because similar to a lot of people, including yourself, the first thing people comment on, right? Like, right, like in a lot of South Asian households, and it's one-sided, it's directed at the women, not so much the men. So what's something about, ideally, weight loss and weight loss medicine, or obesity medicine, what's something that you've changed your mind about as you've gotten older and wiser?
The customer is always right. Back in the day, it became normal to kind of like roll your eyes when a patient sort of came in with a suite of demands. And those patients are typically not received super well. But if you can get beyond the like initial like, that doesn't feel very good, what you will see is that that's a person who is advocating for themselves. And that's awesome. You should roll with that. It's possible they have no idea what they're talking about. That's fine. That's actually not their job. Your job is to say, it's awesome that you're telling us what you need. Because a lot of people don't even bother. So I'm into thinking about this as a customer service model insofar as patients should actually get what they need from their system of care. That's not a crazy thing to think. They don't right now, and they really want it, and we should deliver that.
That I actually really resonate with that, because it used to make me really apprehensive when people like that came in. And over time, I actually love my patients who bring those in, because they're oftentimes also being really critical of what they're consuming.
Totally. It's a green flag.
Yeah. Love that.
I love working with those people.
Yeah. Yep. Okay. Now, where can people find you, learn from you, and or connect with you?
My website is www.ashleywhitemd.com, and I'm on Instagram as ashleywhitemd. And the online program I talked about will be ashleywhitemd.com/shift. And if you want to work with me clinically in Burlington, you can search for clarityhealthburlington.com. And I work with a collaborative team of naturopathic doctors and myself, and we care for patients all together.
Love that. Thank you so much for being here. I really appreciate you taking the time and sharing the nuance and all the things that you think about when you think about weight loss, because I really do think that we need to think about it more broadly and more granularly at the same time. And if this episode sparked something for you, like a shift in perspective, something to reflect on, I would love for you to share it with someone who might also benefit. Ashley's information will be in the show notes, which can be found at facetophase.ca. Follow and subscribe wherever you find your podcasts.